Welcome to this tutorial on interpretation of focused gallbladder ultrasound. My name is Dr. Shuo Peng. I'm a clinical fellow in point-of-care ultrasound at the Ottawa Hospital. How do we identify the gallbladder on ultrasound? The gallbladder is a pear-shaped cystic structure. It has an anechoic or black lumen and a hyperechoic or bright wall. It's in the anterior aspect of right upper abdomen. The median lobar fissure of the liver and the portal veins are landmark for identification of the gallbladder. It forms an exclamation sign together with a portal vein. When the function of color Doppler is used, the gallbladder demonstrates absence of flow. This is a scan of the long axis of a normal gallbladder. Here we see clearly the median lobar fissure and the portal vein. The juxtaposition of the portal vein and the gallbladder forms the landmark exclamation sign. We can also see the right kidney posterior to the gallbladder. In order to perform a complete ultrasound examination of the gallbladder should be visualizing two axes, longitudinal and transverse. Here's a transverse scan of a gallbladder. Note the edge artifact seen here. Once you have located the gallbladder on ultrasound, the next step would be to identify the presence of gallstones. Gallstones are seen as hyperechoic, well-defined mass inside the gallbladder lumen. They produce a posterior shadowing. Stones can be solitary or numerous. This clip shows multiple stones within the gallbladder lumen. Note that these stones cast a sharp and well-defined posterior shadow. When the gallbladder is almost completely filled with stones, it can often be mistaken for bile gas. A way to differentiate bile gas from high stone load is appearance of their respective posterior shadow. Gallstone cast a sharp, dense shadow seen on the image to the left. Bile gas on the image to the right cause scattering of the ultrasound wave, which produce a dirty shadow with diffuse and poorly defined margin. Gallstones are mobile and move to the most gravity-dependent portion of the gallbladder. An important exception to this is an impacted neck stone. This is a longitudinal scan of the gallbladder performed with the patient in left decubitus position. Note that in left decubitus position, the fundus is the most gravity-dependent portion of the gallbladder. However, in this clip, the gallstone is not in the fundus. Instead, it can be found impacted at the neck of the gallbladder. Impacted stone can also be difficult to appreciate. The shadow created by neck stone resembles the normal edge artifact found at the gallbladder neck. It's important to recognize impacted neck stone due to the higher rate of recurrence and more problematic clinical course. Therefore, a careful visualization of the gallbladder neck can help detect clinically significant impacted neck stone. There are several pathologies that mimics gallstones. Like gallstones, gallbladder polyp or mass appear as a hyperechoic mass inside the gallbladder lumen. Note that mucosal fold, gallbladder polyp or mass do not usually demonstrate posterior shadowing. Biliary sludge is a result of biliary stasis. Sludge appear as dependent echogenic material that layers in the dependent portion of the gallbladder. Unlike stones, they do not produce a posterior shadow artifact. But like stones, gallbladder sludge can lead to obstruction and acute cholecystitis. Once you have confirmed the presence of stones, there are certain sonographic features that distinguish cholelithiasis from acute cholecystitis. The following sonographic signs support the diagnosis of cholecystitis. Positive sonographic Murphy sign, wall thickening over 3 millimeters, and presence of pericholecystic fluid. Sonographic Murphy is defined as maximal abdominal tenderness from the pressure of the ultrasound probe over the visualized gallbladder. A positive sonographic Murphy in the presence of gallstone confers a positive predictive value of 92%. On the other hand, the absence of sonographic Murphy carries a high negative predictive value for acute cholecystitis. Wall thickness is measured at the anterior wall of the gallbladder in the transverse axis. Measurements are obtained from outer wall to outer wall. A measurement greater than 3 mm is considered abnormal wall thickening. This clip demonstrates marked wall thickening and the presence of gallstone in a patient with acute cholecystitis. The combination of wall thickening with gallstone presents a positive predictive value of 95%. However, gallbladder wall thickening is not specific for acute cholecystitis. It can occur in ascites, congestive heart failure, sepsis, and many more other pathologies. Pericholecystic fluid is an indication of local inflammation that occurs in cholecystitis. This clip demonstrates the presence of pericholic fluid in a patient with acute cholecystitis. It appears as a hypoechoic irregular collection in proximity to the gallbladder. Similar to wall thickness, presence of pericholecystic fluid is not specific for cholecystitis. That brings us to the end of the presentation. Remember, the gallbladder is a pear-shaped cystic structure located anteriorly in the right upper quadrant. Look for the exclamation sign as a landmark to locate the gallbladder. Gallstones are a hyperechoic structure with posterior shadowing. And secondary sonographic signs supportive of the diagnosis of acute cholecystitis are sonographic Murphy, wall thickening beyond 3 mm, and pericholecystic fluid. In general, it is important to remember that secondary signs of cholecystitis are not specific for the condition. Clinical context remains the most important finding in the interpretation of gallbladder sonography. Don't hesitate to consult these other resources to support your learning, and thank you for your viewing.